Let me welcome on stage Thomas Hügle, who will walk us through the clinical pathway with AI, supported by AI. Oh, you have your mic already. Okay, thank you. You're all set.
Yes,
thank you.
Is it good with the sound? Yeah, so hello everybody, pre-lunch as well. So my name is Thomas Hügle. I'm the director of the Rheumatology department at CHUV in Lausanne. So I would like to give you my view as a doctor in a large institution about AI. And so these are my disclosures. I'm a patent holder and a co-founder of Atron that you've seen before. So you will find 2 or 3 slides that are similar. I would like to explain you medical AI like I see it in 2 slides. Okay? Can't go into detail, but I make it more easier in terms of by showing you Lego examples. But if you understand these 2 slides, I think you understand a lot that you need in medical AI, at least in healthcare organizations. So we're talking about machine learning, right? Doesn't work. Should it? Come on. Sorry? C'est bon? Moi je le vois pas. Ah, because it's here, maybe here. Anyway, machine learning, so learning usually from previous experiences. Okay, so data. Usually it's images, easiest. Static images, labeled images usually. Tumor, yes or no. Fracture, yes or no. Pneumonia, yes or no. Okay, so that's the form of AI we're talking about. And here you need to know 3 types. The workhorse in medical AI is supervised learning on your left. Supervised learning means labeled data. So a radiologist tells, this is fracture, yes, no, tumor, yes, no, etc. Okay, very simple. But you need a lot of people training on this. By the way, at the moment, I train almost as much algorithms as I train young doctors. You can say whether this is a good or bad thing, but at least in the academic center, I do it like this. And the algorithms won't retire, so that's a positive thing. Anyway, so supervised learning is about solving a task. That's very important. It's a simple task. It's not complicated. Tumor, yes or no. Osteoarthritis, grade 0, 1, 2, or 3. Okay, so the algorithms just do that. They don't tell you, oh, but I saw something else, and there is also a rare disease on it. Okay, it's very simple. Okay, so actually, then there is unsupervised learning. Oh, sorry, I missed the Lego part. So in terms of Lego, that says you have to tell, if you have your Lego at home, all pieces. That's yellow, that's 6, that's 2, that's small. Okay, so the machine knows it all. Then the other example, it's unsupervised learning. That's number 2. I would say it's 90% supervised. Well, let's say 85 and 10% it's unsupervised learning what we use. So meaning you have unstructured data, electronic health record data, for example. A lot of data, but not structured. Okay, or in a registry. So we have to bring some order in this data. This could be clinical data, CRP, this could be X-ray, this could be joint pain. So you tell the machine, well, find me similarities, find clusters. What is similar? And then the machine says, okay, I do it. It would say, find 4 types. It's you telling the machine how many clusters you want. It's not the machine finding out, we have actually fibromyalgia is not 1 disease, but 5. You tell how many clusters you want. So here it's 4. Or you say, okay, we cluster by colors, by types here. Okay, so bringing order in unstructured data. And then there's the premium AI. That's reinforcement learning. So reinforcement learning is used in autonomous driving, chess engines, like AlphaZero. So here the machine shown as a little wagon, which is called an agent in AI. It's a mathematical formula at the end of the day. It brings you the Lego to the right place, and it can make mistakes. You would allow the model to make mistakes under one condition. The model has to learn from the mistake to do better. This is done in a so-called Q function. So for example, autonomous driving in the new BMW, the lane detection, this has been developed by reinforcement learning in simulators. And that's a good thing, for example, in autonomous driving. You have a simulator, change the lane, another car, speed, crash, no reward. If you do it well, reward again, and again. With a simulator, like a chess simulator, you can create enormous amount of data. In medicine, we don't have this. We don't have a simulator in medicine. Too complicated. If we had, that would be wonderful AI, but we don't. Okay? We can do it in certain circumstances. For example, in diabetes. Diabetes, you have a very good biomarker, glucose, and you have an action, which is insulin pump. And then you give very strict rules, so not more than 10 units every hour or what have you. Strict rules, you allow the machine to make mistakes in insulin injection if it learns from it. So diabetes most advanced in AI in terms of reinforcement learning. There's also in critical care with catecholamines, with adrenaline injections, where you have a lot of data, blood pressure, etc., that works as well. All right, so this is trial and error here, but we have not this in other fields. So that was one. It's almost over, if you got this. So now, if we are again here, this is FDA approved. I would say 99% are here. So this is either a classification, what I told you, or what I will show you, it's a regression. That's prediction of a numeric value, which I like a lot as a clinician. I like a CRP in future. If there's a patient hospitalized with pneumonia, it's doing better. The CRP, which is the inflammation value, still high. Should I bring him home? Should I let him go home or not? I don't know. Maybe with 20 years experience, I could say, well, come on, do it. But still, yeah. But if the CRP in 3 days, that can be predicted, goes down, I say, okay, come on, let's go home. So there it will help me by predicting a numeric value. And then here again, usually what we do is unsupervised learning, the clustering, I told you. And then finally, there's Gen AI. So is Gen AI now supervised learning, reinforcement learning, unsupervised learning? It's all. It's all. This is a bit the superpower and the success of Gen AI. So it does a kind of self-supervised learning, a lot of data, text, right? It self-supervises what is what. It does unsupervised learning. And as a final step, you have reinforcement learning with human feedback. So for ChatGPT, it have been the people in Kenya to tell that was the correct spelling, for example, correct sentence. $10 per hour for the success of OpenAI. But it's interesting because this is what we do now with Meditron, which is the large language model from EPFL, which is actually also an asset, I would say, of the canton. To having a strong large language model for medicine is a very good thing. So, and I will tell you where you can do this. And we are currently training it with real medical data. So it's not a vision, it's true. It's over 900 algorithms are FDA approved on the market, mainly in radiology, for the reasons I told you. In musculoskeletal, it's, for example, you see there is some fracture detection, because the task is very simple. Fracture, yes or no? You come emergency, your son fall off from the bike like this, the son, well, now it's 2 o'clock, no, it's not at 2 o'clock in the night, shouldn't go for biking, cycling. Anyway, and you have a young assistant doctor, started medicine 2 weeks ago. Oh, can he really detect a fracture? Here, simple question, you do the X-ray, would be checked by the algorithm, fracture, yes or no. So that works. But it doesn't work if there are several questions, osteoarthritis, calcification, other things, arthritis. That's a problem, that we need better answers. But for fracture, it works. Planning CT scans, reducing X-ray radiation, it works. Opportunistic AI works. Haven't you heard about that? Opportunistic AI, meaning you use a CT scan to transform it into an MRI, vice versa. Or MRI to predict the bone density, so you don't need a DEXA. Opportunistic AI, it's on the market now. It's a similar thing. And then finally, a bone assessment, for example, automatic detection of fractures, also in the vertebral and the bone density. All right. This is from our current practice. So we see these are the algorithms that we see in our radiology room, for example. By the way, it's not the big hospitals don't buy it for the reason I told you. It's more the private practices that buy that solutions, but it tells you here's osteoarthritis on the right, not on the left, and it tells you which stage. Same for MRI here, and it's coming now for sacroiliitis, which is a difficult joint. I would like to have this one. This one, maybe for documentation. Now, this is work we do. So if you train an algorithm, and I'll show you the differences of the quality of an algorithm. So we trained this one to detect osteoarthritis in your hands. Different grades, 0, 1, 2, 3, 4. And we trained it with 48,000 joints. Poor doctorant, he scored a lot. Became a radiologist, by the way. So, and if it's that good, you see how pretty the lines are. It's a pity it doesn't work for me here. Okay, so on the left, you see the joint space and the red points. This is a data signal. That's not a biological signal like in a scintigraphy that we are used to, like osteoplasts showing activity. It's just a data sign that the algorithm with the so-called heat map shows you this is why I did my prediction. For example, on the top, it's class 0. It's no osteoarthritis. Here it says, oh, there's an osteophyte. And here it said, oh, that's diffuse, that's severe osteoarthritis. So I'm interested in the classification, but also to learn from the algorithm. Please look here on this osteophyte. Please look here, here could be the fracture. So it will draw my attention, and so it has some educational value. If we do this with less patients, for example, for crystal arthritis, the heat map is more cloudy, less precise. Still interesting, but less precise. And we use that, for example, to screen larger databases where we have to screen 1,000, 5,000 images. For example, in rheumatoid arthritis, and here we could show that those with the calcification respond less to treatment than those without calcification. So it helps us in research and clinical care. This was a LinkedIn post that I liked, so I have to show you that. How can you evaluate an algorithm in clinical practice? Is it good or bad? And as they say, it's in the eye of the beholder, meaning the AI engineer, usually he or she gives me the F1 score, which is kind of accuracy, right? I mean, I can show you this. It's taking into account precision recall, meaning looking at false positive, false negatives. Accuracy. Then, actually, well, the vendor, of course, would like to sell. The hospital, the director says, what's the return of investment? Why should I buy this fracture detection? I have the doctors anyway, and so on. Length of stay. Can you really reduce the length of hospital stay from 10 days to 8 days? Oh, that's interesting, because it's expensive. Then FDA wants sensitivity, specificity. That's what we also like. And the radiologists would like to see the positive predictive value. So meaning, I have this here. So, it's a confirmation. We want to have the AI as a confirmation tool, not a screening tool. Imagine AI would pop up an O positive, 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 fracture, 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 fracture. Then we have more work than before. And we want to have less work because we have too much work. So we rather go for the positive predictive value than the negative predictive value. This is an algorithm that we also trained in 9,500 patients with arthritis, rheumatoid arthritis, 65,000 visits. We trained an own model, longitudinal prediction, long short-term vectory, LSTM, little brother of the transformer. Transformer got famous with the GPT. And we could predict the real cases in 92% at next visit. Okay? So we can really look into the future. Okay, we can also know who is predictable. That's new to me as well. So some patients, long disease duration, seropositive, they're better predictable. We can also see, okay, those cluster, I told you, Lego on the right, have more drug survival in phase 2. So this cluster, but patients change, but during that cluster, they might respond better to treatment X. And then finally, almost done, 1 more minute. We do unsupervised learning, for example, to understand diseases better, like fibromyalgia. And here we had, this were 200 patients, we now have 400, and we actually find out which type of fibromyalgia patients we have, so chronic pain. And then this data, we put in the large language model, and it gave us personas, for me, digital twins. And this is really, we see these patients in perimenopause, perimenopause, 53-year-old, obese, inflammation, osteoarthritis, epicondylitis, etc. Sometimes pseudo-rheumatism. We see these with 35-year-old hypermobile, migraine since childhood or adolescence, chronic pain, sleep problems, depression. We see others. And so that helped me. Actually, the most in my clinical practice is the clustering and then an LMI. Okay. I think I should slowly start. The other thing is to monitor patients. We have a problem that if we take the patient-reported outcome, some type of patients will report more, some less. So some will under-report, and we will see a lot of patients with fibromyalgia or catastrophization. So we have to take care. Mark showed you the way that we use AI to score objectively the AI. We have kind of a scope home. Patient take this and we see at home like a clinical exam, not only the symptoms but only objective measures that correlates. We need dashboards that come together, train it more. And then that's maybe the final slide. We have to understand where are we in the patient journey. Are we on top at risk detection? That's another story. Then diagnostic tools, then treatment tools or monitoring tools. If you know where you are, your process and your algorithms are different. You have to know this. To implement it in clinical practice, we have a test virtual center where we test it, whether it works at home, where we ask secretaries, health assistant, nurses, doctors, do you like it, how it works? How can we do better? Because now UX is almost as much as important as efficacy, right? And then we say, okay, that's helpful. So I don't need to see the patient. I will see him in 6 months, for example. So thank you very much. I think I skipped that. Obviously, Gen AI is super important. It will help us for ladders. That's a no-brainer. For me, that's more the hospital that has to implement this. We started using it already. People, if we not provide it now, our doctors use it, they just copy it in. So it's so helpful that we urgently need it in our electronic medical record. Okay. So with that, I would like to thank the development team, the team at CHUV, and also the spin-off Atreon, and a lot of collaborators all from Europe, from Italy, from Erlangen, Charité, Lars Backhaus helps a lot, Marco Rüdi, who supported us with the InnoSwiss, so the whole team, and thank you very much for your attention. It's good?
Thank you. So I have a question for you. You mentioned that there are different pathways in the clinical, right? So, but also, what about prevention? Is it something in scope right now, or is it... Because we have so many data. So.
Always. Maybe not really now in the hospital setting, but obviously people should not even need to come to the hospital. So the pre-arthritis, so the pre-disease is a step in between prevention and disease. There is something in between. And we are much better in this in between, right? otherwise, prevention means you have to do it in a lot of people. So if we narrow it down for the pre-disease, so some symptoms or blood values already, but no diagnostic, this is what we can do. I think prevention obviously is key as well. We're not working on that.
Another question, do those AI solutions need to be Swissmedic approved or are more used as a research tool?
Currently we use it as research tools, but that's what we want. That's what we are doing for quality management, etc. Important message, it's harder to approve a diagnostic algorithm. Because if it says, you have arthritis, well, that changes my life maybe, right? I may change my job. If it's monitoring, and that's what we do, it's easier. So a doctor has done the diagnosis, and we are just measuring something, with, for example, the phone that usually takes you 20 minutes to measure by examination. So answer is yes, but it depends. Better monitoring.
Thank you very much.
Thank you very much.
All right.